I hope that you have been enjoying this series of webinars from the Regional Surgical Advisors of the Royal College of Surgeons of Edinburgh. We would like to thank the College for the opportunity to present to you today. There are over 40 Regional Surgical Advisors, or RSAs. We are consultants and fellows of the College. We provide advice and support at a local level in the UK. You might have met us in your local teaching events or in careers fairs. If you want to get in touch, please look at the college website for further details regarding your local RSA. Today's topic is copious vomiting due to gastric outlet obstruction. Mr. Paul Gallagher will be our speaker today. Paul is a consultant general surgeon at Northumbria Healthcare NHS Foundation Trust. He trained in the Northern region and after a fellowship in Adelaide, Australia, took up a post as a consultant upper GI surgeon. Paul is currently the head of School of Surgery for Health Education England, North East and Cumbria. He oversees the training of all surgical trainees in the region. He is a current examiner for the FRCS and the former MRCS examiner. He is a fellow of the Faculty of Surgical Trainers. Please remember that during the presentation, you can use the Zoom button Q&A facility to post questions, and we will try to answer as many of them as we can. You can vote with the thumbs up button as to which questions you would like most answered. Over to you, Paul.
Thank you, Cynthia, and good afternoon, everyone. We're going to talk about gastric outlet obstruction today. And the first slide that we have really illustrates a massive stomach. You can see outlined by red, occupying all of the abdominal cavity because of an obstruction at the outlet. And after a few introductory slides reviewing anatomy and physiology, I'm going to go through some illustrative cases that will take us through the management strategy for these patients. First of all, if we think about the functions of the stomach, it acts as a reservoir and starts the digestive process. It produces acid, both as part of the digestive process and to neutralize any pathogens that are swallowed. It produces enzymes and also has an endocrine function, as well as being the starting pump for GI motility. So when there's a disorder of the stomach, different things can be affected. Fluid balance of the patient, principally because the stomach produces a lot of electrolyte-rich fluid, which is vomited, and no fluid can be absorbed if it's completely obstructed. Nutrition, if the issue is a chronic issue, nutrition will be affected. In terms of diagnosis, it's often a dilemma in the adult between is this a benign or a malignant process, as we'll discuss. And then generally our management options are either medical, surgical, such as a bypass of the obstruction or to resect the obstruction, or sometimes a stent to pass through the obstruction. As a reminder of your basic anatomy, the stomach is in the upper abdomen and comprises a cardia, fundus, body, antrum, and a pylorus. And this is the outlet of the stomach at the pylorus. It is made up of different layers of muscles and has an inner lining of mucosa that has cells that produce acid and enzymes, amongst other matters. The duodenum at the outlet of the stomach is best seen as a C-shaped loop with the pancreas embedded within that. And problems with the pancreas or the duodenum can also block off the outlet of the stomach and cause issue as well. One of the main diagnostic workhorses that we have for working out the issues is CT. And this is an illustration, an old CT showing contrast that's been swallowed orally in the stomach in both a coronal and an axial section as outlined in red. You can see that the stomach occupies a reasonable amount, but we'll have much larger stomachs when we review some patient scans. Our other main diagnostic tool is endoscopy. This is a picture of the stomach looking down from the esophagus and then looking back on ourselves. And finally, this little black pinhole on the slide here is the pylorus. And notice how nice and clean the mucosa looks, pink and healthy. When we go through the pylorus, we'll enter into the first and second parts of the duodenum. So we'll go through some cases now, and our first one is a 68-year-old, somewhat frail with a previous myocardial infarction and COPD, who's an ex-smoker. She presented with several weeks of indigestion, which was a vague term, to a general practitioner. But because of these symptoms, the general practitioner referred directly to the hospital for a gastroscopy. In fact, this showed suspicious extensive areas of apparent tumour in the antrum and pylorus, from which multiple biopsies are taken. And you can see on this illustrative gastroscopy picture, there's slough of the mucosa. We've lost the nice pink mucosa. There's some bleeding from contact, and it all really looks rather unpleasant. Now, she started having trouble keeping food down just as the results of the biopsies became available, which showed adenocarcinoma, so a malignant process of the stomach. And a CT was performed to stage the tumour to see how extensive it was and if it had spread. Now, from this CT, you probably get the idea that the stomach is much bigger than on the initial pictures I showed you of the normal anatomy. And in addition, there's thickening along the antrum and pylorus, suggesting a tumour. Not shown on these slices, but there was also very small nodules, perhaps 0.5 centimetre or so, in the peritoneum and omentum, suggesting that this was a metastatic process from a primary gastric tumour. And we had biopsies showing adenocarcinoma. So in UK practice, we can refer to NICE guidelines from the National Institute of Clinical Excellence on how to manage such patients. And for our particular patients, when we go through our management algorithm, fluid balance wasn't as yet a problem. They were still an outpatient and appeared well hydrated. Nutrition, although they'd been losing some weight, there was no profound nutritional deficits. The diagnosis, which was a difficult diagnosis and conversation to have and explain to the patient, was explained. And really, we didn't have many management options. So in this particular situation, resecting the obstruction, the tumour, would be futile, as we wouldn't be able to cure the patient of her gastric cancer and would put her through major surgery for no real benefit. A stent was probably the next best option, as trying to bypass this obstruction can be technically difficult. So the options were discussed with her, and the patient decided that she would like to have a stent inserted to hopefully improve her quality of life. The image that we have here is an endoscope, which is the large black tube, with a guide wire coming through the end of it under X-ray control, and that we perform this with the patient under sedation. And then over that guide wire, you can push a self-expanding metal stent, which will open up progressively to relieve the obstruction. And you can see the outline on the plain X-ray here, coming around the first and second part of the duodenum. And then on a follow-up CT scan, we can see the white circle of the stent. And the distension of the stomach has considerably improved. So for our particular patient here, her symptoms improved. She was managing a sloppy diet and fluids and managed to be at home until she died several months later with community palliative care input. Our next case also involves a tumour, but is contrasting. An 82-year-old gentleman who was previously fit and well and presented as an emergency to hospital with a 1-week history of vomiting and dehydration. He was commenced on intravenous fluid therapy, and it was noted straight away that he was vomiting what was termed as coffee ground. Now, this is a term that you may come across. Sometimes when the mucosa becomes inflamed, it can bleed, or an ulcer can bleed. And unless it's immediately vomited as bright red vomit, it will change and get denatured by the heme to produce a brown colour, which when vomited up looks like coffee ground. So the patient went straight away for a gastroscopy, but all that could be seen was a large amount of food and fluid in the stomach. And a CT was organised, which was performed after we'd rehydrated the patient. This has shown some abnormal tissue. So in this slice, we have a dilated stomach. This is a slightly more difficult slice that we're lower down in the body. And we're seeing here the duodenum, which is much more dilated. And then an appearance of tissue here, which we can see on this coronal section. Here's the stomach coming around the dilated duodenum to stop in this tissue mass. The CT unfortunately also indicated that there was metastases to the lymph nodes and liver metastases. You can see some white things here, which are the arteries coming off the celiac trunk of the aorta, where the lymph nodes are located, and the tumor had spread to this area. An endoscopy was possible to perform a tissue biopsy after nasogastric decompression. So we look at what our management problems are in this particular patient, and fluid balance was definitely a problem. The patient had an acute kidney injury, which required 72 hours of rehydration. Prior to all this, he'd been really very fit for his years and had been out and about, fully active, with no restrictions on activity. We discussed matters with the patient and discussed through options, and he was keen to consider any intervention as he'd had such a good quality of life up to this point. Now, of our different options, again, resection would probably be inappropriate, as we'd be leaving tumour behind and put the patient through a large operation for what would ultimately be an incurable disease. Technically, a stent could be quite difficult because we need to go all the way around the duodenum to the third part to be able to deploy the stent. And therefore, we decided to perform an operation to bypass the tumour, following which the patient would be considered for palliative chemotherapy. And this diagram shows the esophagus, stomach, and duodenum with a normal flow of food and fluid being blocked by our tumour here at the third part of the duodenum. What we're able to do is bring up, as illustrated in these red lines, a loop of jejunum to anastomose, or to join to the stomach, so that the food can flow from the stomach and bypass the obstruction to go down this limb of the jejunum to continue into the intestines. And we describe an efferent limb going away from the anastomosis and an afferent limb coming into the anastomosis. There are very good videos that you'll see on the internet that will illustrate the operation should you wish. So our patient made a good recovery from this and was able to eat and drink and discharge from hospital. Now, when we consider his fluid balance problems, we need to look at the basic physiology of what's going on in the gastric mucosa. And on the luminal side, hydrogen ions are being excreted along with potassium ions and chloride ions as well. On the blood side, bicarbonate, because of the loss of potassium from these cells, enters into the bloodstream. So persistent vomiting of gastric fluid produces dehydration and can produce an acute kidney injury, hypochloremia, or a low chloride in the blood because of this loss of chloride ions, and a metabolic acidosis, metabolic alkalosis because of the loss of hydrogen ions. Now, the dehydration and this ionic imbalance is usually corrected by intravenous fluid therapy. And at the same time, once you've rehydrated things, this will correct any acid-base imbalance. Occasionally, with profound dehydration, the kidneys will try to save potassium and paradoxically excrete hydrogen ions, which can worsen the alkalosis. With fluid balances that have been disturbed for several days, you need to correct over several days, particularly in our elderly patients who might have problems with heart failure and be on diuretics. And there's a difficult balance between rehydration and overload. The other thing that we'll see is quite often patients have been put on proton pump inhibitors, medications to switch off acid because of their symptoms, and have a delay in their fluid balance. A disturbance as a result of that in their fluid balance. Our next case is somewhat different, and I'll let you look at this picture for a few seconds, which is a barium meal. And what we're seeing here is the esophagus, the duodenum, and this is the stomach. But what's wrong with it? Well, effectively, it's upside down because it's flipped up into the chest. And this is what we'd call a gastric volvulus. The stomach may flip along its long axis that we call an organoaxial volvulus, or on its short axis, which we'd call a mesoenteric axial volvulus, or it can be a mixture of the two. As in this case, it's often secondary to a large hole in the diaphragm through which the stomach can push through into the posterior mediastinum with a paraesophageal hiatus hernia. Occasionally, primary volvuluses will occur. In this particular patient, it was a chronic volvulus, and she presented with chest pain on a background of many years of indigestion to a GP, and this investigation had been organised. And we were discussing the merits of whether to repair this with the patient to prevent complications when she presented as an emergency to the A&E department with severe chest pain. And what now would be the question? Well, cardiac causes and other chest causes of the pain need to be excluded. But in fact, when we reviewed the history, she had severe chest pain, a strong desire to vomit with retching, which was actually not bringing anything up. And when a nasogastric tube was attempted to be inserted, this wouldn't pass. And what we effectively have is the stomach is completely twisted so that the esophagogastric junction and the duodenogastric junction are both obstructed. The stomach is progressively filling with gas and fluids, so the blood supply into the stomach wall becomes affected, and the stomach can form necrosis and die, which is usually a fatal condition. So often an emergency operation is required, ideally after nasogastric tube decompression, to relieve this. Again, there's many good videos available on the internet, but this is an illustration on the top picture of us looking from the umbilicus up to the diaphragm, which is at the back with the liver, and you get the impression of a hole with the yellow omentum being stuck in the hole. And when we gently pull the omentum down and the stomach, which is a little bruised along there, we can see this large hole or paraesophageal hiatal hernia. Again, this patient had an uncomplicated repair by laparoscopic surgery and has had a good quality of life since then. Our last patient is, again, somewhat different. This is a 62-year-old lady with a significant past psychiatric history, including self-neglect. She'd been taking non-steroidal anti-inflammatory drugs for some years and had progressively declined over several months. Eventually, she was admitted to hospital with dehydration and an inability to manage at home. And when she was vomiting, it was seen that the vomit was actually not bilious stain, but relatively clear and containing fluid and food. Now, there was no bile there because the obstruction was at the duodenum pylorus, below where the bile duct joins onto the duodenum. When she was examined, she seemed to be profoundly cachectic, which means that she'd lost an awful lot of weight, which was very visible, and what we'd call a succussion splash. So you can imagine with this CT of the patient here, this is a large fluid-filled stomach, is that when you gently move the stomach and abdomen from side to side, you can hear a splash in these patients who are chronically obstructed. After rehydration and nasogastric decompression, it was possible to get views at endoscopy. And the view that we're seeing here is ulceration in the duodenum. And this is slightly different from the malignant cancer case that we saw, first of all, that there's a clear margin, but extensive biopsies are needed of this just to make sure it's not a tumor. So for our diagnosis, first of all, the gastroscopy was performed and the biopsies had only shown inflammation. There was no evidence of any malignant cells. A CT that we've seen had not shown any mass lesion or thickening suggesting a cancer, and there was no evidence of metastases. So putting all this together, the appearances were of probably severe benign duodenal ulceration causing a gastric outlet obstruction. But sometimes when we do the biopsies, we do not get representative samples, and this can be a false negative, and in fact it is a malignant process. While awaiting the results of these biopsies, we managed the patients with intravenous proton pump inhibitors to reduce the acidity and hopefully improve the inflammation, intravenous fluid replacement, and in her in particular, there was a concern about nutrition because she'd lost so much weight and was profoundly malnourished. Initially, we commenced parenteral nutrition, which is intravenous nutrition of carbohydrates, proteins, fats, essential minerals and vitamins. But ideally, one treats a patient with enteral rather than parenteral nutrition as it has less complications. What we're able to do was, using an endoscope, place a guide wire through that very tiny narrowing in the gastric outlet and place a tube over that, which we're seeing here is this coiled tube which is coming through the pylorus around the duodenum right through into the third part of duodenum. And this allowed enteral feeding from nose down into the duodenum through the obstruction for several weeks until she was fit enough to consider further therapy. Now, during this several weeks, it was not possible for her obstruction to relieve by medical means. And again, we had to consider a gastrojejunostomy as a surgical bypass rather than a stent, because of the degree of inflammation and scarring just made a stent insertion not possible. So this is a different problem with somebody who's profoundly malnourished and requires close liaison with our dietitian team as to appropriate nutrition. Probably needs several weeks and then several months at home to fully correct the nutritional deficits. One particular concern is refeeding syndrome, which is important and you will encounter on the ward. So when we start feeding glucose, amongst other matters, into the patient, an elevated blood glucose level leads to an increase in insulin and a reduction in glucagon levels. This stimulates glycogen, fat, and protein synthesis, as the body now thinks that food's available to increase the stores. This process of synthesis requires phosphate, magnesium, and cofactors such as thiamine or vitamin B. The insulin also causes potassium to move into cells, along with magnesium and phosphate. And these processes profoundly decrease the results of serum levels of phosphate, magnesium, and potentially potassium, all of which have already been depleted by malnutrition. This then produces a significant risk of cardiac instability and death. So very close monitoring is required of the patient, and replacement of potassium, calcium, phosphate, and magnesium almost on a daily basis to check all of these on the blood tests and replace them individually as needs be. When we start feeding patients, we feed at quite a low rate and then we'll increase further from there. There are good guidelines, again, available from the National Institute of Clinical Excellence on how to deal with refeeding syndrome. So it's well worth brushing up on this before you go to the wards. On the last couple of slides, just to mention a few atypical causes of gastric outlet obstruction. A foreign body will occasionally cause an obstruction. In this particular slide, a spoon, which would be unusual. More typically, it might be a teenage girl with long hair who chews her hair over many years and forms a ball of hair in her stomach, which can be removed endoscopically. The other cause is something pressing from the outside, an extramural cause. And you can see the outline of a plastic shape here, which is a band, which has been placed historically in an attempt for the patient to lose weight, but has slipped, producing a complete obstruction to the stomach, and it needs removing. Finally, we deal with infants and children, and there is idiopathic pyloric stenosis, which is due to a thickening of the pyloric canal. Now, typically, babies a few weeks old, more often male than female, and cannot keep milk feeds down. And often the milk will curdle as the acid in the stomach will change this so it appears yellow. Diagnosis is by a test feed, and you can sometimes feel a lump in the right upper quadrant, or these days use an ultrasound to confirm the diagnosis that there's a thickened pylorus. Management thereafter is usually straightforward, and after rehydration, an operation to just divide through the layers of the muscle that are thickened, but not the mucosa. So in summary, our priorities are fluid balance and nutrition. We can then, at the same time, work up through diagnosis using CT and endoscopy, and then a variety of management options can be used depending on the individual patient's diagnosis. Thank you.
Thank you very much, Paul. Great presentation. We've had a few questions that have been sent by our participants. The first one is, what are the complications after pyloric stent insertion?
So it's usually a safe procedure. Quite often the main issue is that it doesn't work, that you cannot get a successful deployment, and it does not work, and you need to think of another option, such as the operation. It can cause perforation of the duodenum, or it can cause hemorrhage. But usually it's successful and will last for several months, and we're usually using this in the context of a malignant process, and that will manage the patient for the remaining time.
There's another question asking, are there any medication that can help, like in bladder outflow obstruction? Can you use things like alpha receptor agonists?
So that's a good question. Unfortunately, with these processes, there's usually a great degree of scarring in a benign condition. So if a patient has gastric or duodenal ulceration, if it is going to settle, it will usually settle on intravenous proton pump inhibitors and time. But because it's so scarred, or muscle relaxant agents or antispasmodics, unfortunately, do not work.
Okay. There's another question saying, can it be so significant that gastric outlet obstruction causes abdominal compartment syndrome?
Usually not, because the patient's vomiting. So it won't completely obstruct so that the abdomen's under pressure. For those who don't know what abdominal compartment syndrome is, sometimes if you get bleed or fluid within the abdominal cavity, it can cause an increase of pressure with the abdominal cavity that will affect organ perfusion. But because the patient's vomiting, that will relieve things. In our last case, where we had a massive stomach, there was chronic distension over several months, and the body had adapted to that as a result.
Okay, we've got another interesting question, which you probably mentioned in your presentation, but which is important. And the participant is asking, what is the fluid of choice when resuscitating patients with gastric outlet obstruction?
So there can be a great debate about this, but an intravenous crystalloid will usually suffice. So that could be normal saline or Hartmann's fluid. There might be some discussion of whether you should be using a pH neutral fluid or fluid that might contain bicarbonate. So I would generally use normal saline, perhaps with potassium replacement as needs be, and usually that will correct most things. We don't need things generally like double strength normal saline or other issues like that, but time will correct it, but very tight fluid balance, so the patients will need catheters, close observation, just to make sure that they're getting sufficient fluid and don't develop significant renal impairment.
And finally, Paul, two questions about gastric volvulus. One is, what are the causes of gastric volvulus? And the second is there a role for PEG for chronic gastric volvulus?
So the causes typically are secondary, as in the hiatus hernia that we described. So the most typical appearance will be somebody who's had reflux for 10, 20, 30 years of acidity and burning from a hiatus hernia. So that's where the diaphragm has the esophagus coming through, and progressively it can dilate and allow the stomach to come through, and eventually all the stomach will come through and twist around. Occasionally we'll see primary gastric volvuluses with a very high diaphragm that can occur. Historically, things such as trauma would occasionally cause a defect in the diaphragm that could allow the stomach to migrate in the chest and rotate around. PEG tubes, so that's using an endoscopy, you can penetrate from inside the gastric wall all the way through to the skin and place a tube there with the idea of fixing the stomach in place. Now, generally for most patients, they're often fit enough, even though they're very elderly, to undergo a laparoscopic repair. Now, that might be a more simple option, such as pulling the stomach down and stitching it in place, that we'd call a gastropexy, or it might be a complete operation to repair the hiatal defect. PEG is described, you place by an endoscopy, because the patient does need a general anaesthetic, but I've seldom seen it used in my practice.
Thank you very much, Paul. Lovely presentation. May I remind everyone that the next presentation will be on the 23rd